pleasure to be here. I had a very uneventful trip from New York yesterday. Unlike a trip that I had to Vancouver some years ago, I was invited to give a talk, I think, to maybe the Prime Minister and staff in Vancouver, in British Columbia. I had been on vacation with my family in Martha's Vineyard, and so on a Sunday, I got on the little puddle jumper in Martha's Vineyard up to Boston, and then Boston to perhaps Toronto, Toronto to Vancouver. But along the way, I found out that my bag was not coming with me, and I was wearing kind of a t-shirt and shorts, and it was a Sunday, and I had to be up at like 9 o'clock on Monday morning, so I was quite panicked about it. I emailed my kind of host in Vancouver and said, I don't have my bag, I don't have any of my clothes. And he said, well, what size are you? And I said, well, I gave him my height and weight and my shoe size. And he said, gee, that's about my size. So he met me at the airport. And when I arrived, he basically gave me a suit and a pair of shoes and a complete set of clothes. So that worked out. I was only there for one day, and at the end of the day, he drove me back to the airport, and I gave him all his clothes back and got into my t-shirt and shorts. So that was, fortunately, I didn't have to do that today. So, well, thank you again, and I'm here to talk about my most recent study of Canada, which CHPI published recently. I have a slightly different title, I tried to assess the impact of pharmaceutical innovation on two important health outcomes, mortality and hospital utilization in Canada between 2000 and 2022. I had done a previous study that had a similar research design that was published in 2019. That covered the period ending in 2016. So I did publish an earlier study, let me tell you about what the research design. How do I attempt to assess what the impact of pharmaceutical innovation has been on the burden of disease in Canada? Well, it's really pretty simple. Using data from the Canadian government and IQVIA and other sources, we can measure for different diseases how many chemical substances, how many drugs have ever been launched in Canada over time. And if we go back to 1980, so here are 6 diseases. And I selected those diseases because, in this example, because they all had the same number of drugs ever launched in 1980, that is 6. But over the next 36 years, things evolved quite differently. So there were essentially 14 new drugs for treating ovarian cancer, but there were only 7 new drugs or 6 new drugs for treating bladder cancer. So I have a very simple hypothesis that I would expect that there would be a greater reduction in mortality from ovarian cancer than there was in bladder cancer because there's been more innovation. That's a very simple hypothesis. We call this a difference in differences strategy. So we're looking at the difference between 1980 and 2016 and the difference between one disease and another disease. So that's how I assess, that's how I measure pharmaceutical innovation, so that's the overall research design. Now, why do this study again? I mean, I already did it for 2016. Why redo it? Well, things have changed a lot. So if we look at mortality on the left, premature mortality, that jumped up quite a bit, obviously related to COVID in 2020 and stayed up for a couple more years. So that there was a big jump in mortality from COVID. And there was also an increase in the length of hospital stays, so that rather than being in the hospital for an average of 7.4 days, that had gone up to 8 days by 2022. So things have changed, and so it's worth asking, if we redo the study over this longer period, which saw some dramatic changes at the end, do we still get sort of similar results? And so what I did was to re-examine the impact that pharmaceutical innovation had during this longer period out to 2022. Those were the most recent data available at the time. I also incorporated some additional data, in particular provincial data. So what I just showed you were national trends in Canada, but I discovered that there were some provincial data that could also be used. And I know a lot of you really like equations, so I just thought I would show one equation. And essentially, what I'm doing is I'm estimating what's called a two-way fixed effects model, where I'm looking at different measures, say, of mortality from a disease in a year and relating that to the number of drugs that had ever been launched in Canada for that disease. And allowing for lags, I'm going to allow mortality and hospital utilization to depend on the number of chemical substances that had been launched up to 30 years earlier. So it's like, yes, a new drug might get approved today, but that's not likely to have an instantaneous effect on mortality, because it takes time for that drug to be used widely. In fact, we have data on that. So using IQVIA data, where we have data on the sales of each drug in each year, we can measure sort of the diffusion of drugs. And what we see when we look at diffusion is that it seems to take about 12 to 14 years after launch for a drug to reach peak utilization, so that even after 5 years, the drug is only used about 60% as often as it would be used after 13 or 14 years. So there's slow diffusion of drugs, and therefore I would expect that, say, mortality would depend more on how many drugs were available 13 years ago than how many are available or had been launched today. By the way, not only is there a diffusion lag, but there's also what is called in the literature time to benefit. So even though people start taking a drug, it may take several years for that to have its full impact on health. For example, statins, like you might have to be on statins for 5 years before you get the full reduction in mortality from statins. So there's likely to be a long lag as a result of this gradual diffusion and time to benefit. And so when I estimate my model and I allow for different lags, what I find is indeed, I don't really see an effect on mortality in the first 6 or 8 or 10 years. And I'm looking at different measures of what's called premature mortality, mortality before the ages of 85, 75, or 65. But what we see is that the dark black squares represent where we see a significant effect, and it is a negative effect. And in fact, the largest effect seems to occur something like 20 years, so that the amount of mortality today depends on how many drugs had been launched 20 years ago. That's what the data indicate. And again, that's plausible because of the gradual diffusion of drugs and the fact that there's time to benefit. So when I take my estimates, that actually the simplest way to represent what the effect is we can look at, say, the number of years of life lost before age 75. That means that if somebody dies at age 72, they have lost 3 years of life before age 75. So what we do is we look at all the deaths, we add up the number of years of life lost, say, in this case, before age 75, and we can look at the trend in that. And what this implies is that the actual number of years of life lost increased a little bit from about 1.5 million to 1.7 million. That's due to population growth and aging of the population. But the counterfactual is, suppose there had been no innovation. Suppose that the number of drugs ever launched had not increased. Well, my estimates imply that in fact the number of years of life lost in 2022 would have been about 2.6 million. In other words, drug approvals during this period many years ago reduced mortality before age 75 in 2022 by 847,000. That means 847,000 people got to live an extra year because of the drugs that were launched during that roughly 20-year period. So that's what the mortality results look like at the national level. And so, by the way, there's often a discussion about so-called Me Too drugs. That is, once you have a new class of drugs, does it really matter if you have additional drugs within the same class, so-called Me Too drugs? So I also am able to assess that. I look at how many classes of drugs have ever been approved versus the number of drugs approved. And I do find that the authorization of new classes of drugs has a more immediate effect on mortality than the authorization of the number of drugs. However, in general, the effect of the number of drugs is more significant and larger than the number of classes. And that may be because if a new class of drugs is important, it's likely to attract a lot more entry. So we'll see a lot of substances if the class of drugs is important. If it's unimportant, we won't see that many drugs. So that may explain that result. So I also look, because another thing that we can mention, we can measure quite easily from published data are hospital utilization by cause and year. So how many people are in the hospital? How many discharges are there? How long do they stay in the hospital? So we can measure, using a similar methodology, the effect of the number of drug approvals on the number of hospital days. And my estimates imply, I have sort of a similar chart where we can look at how many, in 2000, Canadians spent about 21 million days in the hospital. And that had increased to about 26 million by 2022. However, what my estimates indicate is that if there had been no innovation for many years prior, that in fact 30 years before, that the number of hospital days would have been about 40 million rather than 26 million in 2022. And that implies that essentially that the drug approvals that occurred between 1970 and 1991 reduced the number of hospital days in 2022 by about 14 million. And of course, hospital care is quite expensive. And what this implies is that the reduction in hospital expenditure in 2022 was about twice as large as 2022 expenditure on all prescribed medicines. So extremely cost effective, in fact, cost saving. By the way, I think there may be other savings that I'm not capturing. I've done some work for the United States where we have data on long-term care. So how many elderly people live in nursing homes? Why are they there? And how is that related to the availability of medicines for their medical conditions? And I find that, in fact, pharmaceutical innovation has reduced use of long-term care as well as hospital care like this. At the moment, I don't think data like that are available for Canada, but perhaps they are. As I mentioned, I discovered that there are some provincial data available on how many drugs are covered in public drug program formularies by province, disease, and year. And I can relate that to the age-adjusted mortality rate from that disease in that province in that year. And that allows me to control for many potentially confounding things, like I control for what the effect of a province is, a disease, and so forth. And I found that the age-adjusted mortality rate from a given disease in a given province in a given year is significantly inversely related to the number of drugs that are used to treat that disease and that were covered in public drug program formularies in that province 4 to 12 years earlier. And so, we can see this relationship at the provincial level as well as at the national level. So I would just want to point out, mortality and hospital utilization, those are certainly very important health outcomes, ones that we care about a lot, but they're not the only ones we might care about and want to study. We might also want to study the impact of pharmaceutical innovation on ability to work and quality of life in Canada. I'm not sure that anything has been done about that. I have recently discovered that it might be possible to study those issues using data from the Canadian Community Health Survey. I believe that the public use microdata going back to 2000 are available. They interview people, like 100,000 people a year. They ask them what medical conditions they have, whether they're able to work, and so on. And so one could study those outcomes as well. I've published a number of studies about this topic using data for the US and European countries. I think it would be interesting to do that for Canada as well. So possible area for future research. Thank you very much.